invite Dr. Ashutosh for this talk on can diabetic foot ulcer heal? Yes, no, how? Dr. Ashutosh Shah is a plastic surgeon, a very renowned surgeon, a very good human being, as per experience of all, attached to many hospitals of Surat, and has special affinity and efficiency in managing diabetic foot. So we give him this topic. Another point I would like to say is he is very fond of music and songs. So people in the theatre hear him chanting songs throughout his surgery, and that makes his work very perfect, I think. So over to you.
Thank you for a nice introduction. I'm thankful to the organizing committee also. Surat Diabetic Foot and Ulcer Clinic is one of the only of this kind for dedicated to diabetic foot and ulcers. So my topic today is can diabetic ulcer heal? I'll start with two case presentation. One case was unusual dorsal foot ulcer in 65 years old male. He was having this ulcer for last 3 months, and he was having this dressing repeatedly, and now he came with minimum pus discharge. So probe test was positive. So I wanted to tell all of you is probe test. If you see ulcer, foot artery, mosquito or any culture swab, if it goes deep, then don't do dressing, refer it to higher center. So this is the patient, and on very first day he came to us with this. After 3 months, debridement was done, and you can see the exposed bones, capsules were removed, tendons were exposed. Third day, similar dressing, and on 7th day, the wound was clean and now to be closed, but still the closure was not possible. So we did partial closure, still the bones and tendons were exposed. So we did the peroneus bradish flare. This is the peroneus muscle which covers the wound. And you can see this is intra picture and and this is on 38th day. One time this big ulcer was over and patient was able to walk on his foot. The other case was of the same kind, but it was referred after 3 months. Here, when we refer to early to plastic surgeon, the debridement you can do anywhere. We can cover any defect, and patient stay in hospital and overall suffering is less. So the second case was also dressing done for 3 months, and when he came to me, it was like this: exposed calcaneum and totally heel loss, and there is no granulation for last 3 months dressing. So we did the angiography, and then angioplasty was performed. On 15th day of my visit, he again referred to me after angioplasty, and you can see the improvement in the wound. Now the bone was exposed. Then what to do? So what we did was, this is the vastus lateralis muscle with its artery and vein, and we joined the vastus lateralis muscle to the posterior tibial artery and vein, so that the vastus lateralis muscle will cover the calcaneum, and similarly on the same day we did the skin graft. So in diabetes also you can do free microvascular flare, and same patient walking on the heel. So these big wounds also can heal within 20 to 30 days time. But the answer here, this saves amputation and everything. So refer to plastic surgeon early, it will give patients very advantage. But do we really need to treat such extreme patients? Is there any way can we heal the ulcer in primitive stage, or we can prevent ulcer to happen? So there's the new thinking which I will be taking to you. So diabetes is most common food complication. They happen in 15%, and diabetic patients have 15 to 40 times more amputation rates than the other patients. So when we are talking, every 20 seconds one patient is losing his limb due to diabetes, and so the prevention is better than cure. Now, as you know, all diabetes complications called cellulitis, gangrene, death, anything is preceded by 85% of patients have small innocent looking ulcer, and that ulcer, if we treat at time, then all major complications can be prevented. Now you know all happens due to neuropathy, limited joint mobility and ischemia. I don't waste time on that. This is the pathomechanics, how the pressure will cause ulcers in diabetic foot and mostly on the plantar sides. So in 1992 it was found that the sensory loss and excessive pressure are the cause of plantar ulcers. Now the sensory loss cannot be reversed. So what we can take care of is high or excessive pressure, and it's called offloading. When you offload a food means you reduce, redistribute or remove the detrimental force. When you are walking, there are forces on food, but you can reduce the detrimental forces, and it's called offloading. And offloading will reduce the excessive force, thereby it causes healing. So many of the doctors, when meet to us, they ask, what do you dress with the diabetic food, what do you apply on that? So I told that Bolton said that it's not what you put on the diabetic food that heals it, but rather what you take off, means a pressure. So when you take off the pressure, it will heal. So there are staging of diabetic food. So we usually in India now we get is grade 3 and grade 4. But our aim is to treat them at the grade 2 level so that the complication will not happen. So external offloading, you all know, these are the contact casts and all. I'll show in small detail. Contact cast is the application of plaster. This is the healed wound. Similarly, if the patient is not ready for plaster, you can remove removable cast. Even this type of shoes are also available. This is my patient healed with the shoes design. Customized install also are present. In the foam, the negative impression is taken, and this is one of my patient healed without any surgery. Similarly, peg assisted, where you have ulcer, you can remove that pegs. So its offloading is done, and this is one of my patient. So major problem with the external offloading is it disturbs the daily activity. You have to have cast, and you cannot take bath, you cannot go to field and anything. So it's very heavy and bulky also. And also it increases the fall in the elderly patient, as well as the gait is also changed. And diabetes is Raj रोग. So बहुत सारे businessmen होते हैं जो ऐसे कास्ट पहन के business में नहीं जा सकते. So you need something which is done without external offloading. Even the external offloading will cause healing in 2-3 months time, and again the patient, when it puts the food on the ground, it also recurs. So now what? Rethink, and it's called internal offloading. So why plantar ulcers are common? As they bear the weight, and these are the changes which causes ulcers in the foot. Now we do biomechanical surgery. In that, you know that biomechanics will change the things, and you can every ulcer has special biomechanics and special surgery declared to that. So internal offloading will change the posture, mobility, and deformity correction. So you're not required to add any special type of footwear, and you can have the things from inside. And these are the way we measure the extra foot pressure on computerized scan, and we decide the surgery. And other investigation also are for neuropathy, biophysiometer, vasculopathy, and also the angiographies. So my representative cases, callus, when you remove callus, you reduce 30% of the pressure, and this is the callus excision done under local anesthesia. Now the common site for ulcers are either deep ulcers, it can be at the IP joint, or it can be at the metatarsal or midfoot or hindfoot, and rarely ulcer. So I'll talk about this. So it's great to, if you have deep ulcer, nothing. So if you have deep ulcer or IP joint ulcer, if you have deep ulcer, so your FHL muscle is pulling your toe down. So when you cut FHL in OPD, the ulcer will heal within 7 days. If you have IP joint, it means your thumb is stiff due to plantar fascia, and if you need to taste it, and if you taste it and the thumb is fast, then you can do the plantar fasciotomy with the needle in OPD and the ulcer is healed. But if it is structural thing, then you need to do minor surgery. You remove the proximal phalanx of the great toe and the intrinsic muscles are relaxed. And you can see this 7 years ulcer healed within 3 weeks. Similarly, ulcers on minor toe, it can be due to mallet toe or claw toe or hammer toe. And all this, if correctable, done the soft tissue procedures. If non-correctable, bony procedures are done. And you can see here the only OPD procedure with needle was done, and it's called flexor tenotomy. And this kind of ulcers will heal within 7 days to 24 days. If it is claw toe, then bony procedures are required. Now, ulcers on forefoot are due to mostly contracture of tendo Achilles as well as the fixed metatarsals. And if it is on first metatarsal, you need to save first metatarsal as it causes 40% of weight bearing. So it's called Jones transfer, where we transfer the extensor hallucis muscle to metatarsal and then the ulcer is healed. As while walking, that metatarsal which was pulling, now it is pulled up. Now it's called pronation of foot, where the patient walks, this pull is pulled inside. So medial side is taking more weight. For that we do the peroneus longus muscle is cut and is joined to peroneus brevis. So this is healed wound within 21 days. Similarly, forefoot ulcers happen due to the tendo Achilles contracture. So when you release tendo Achilles contracture, it will heal also will take weight. And we can test it with the silver scaphoid test. And various levels we can do the release of tendo Achilles. And once you release the tendo Achilles, this forefoot ulcer will go away and heal also will take care in the weight bearing. So similarly, modified Jones and the TA release was done. If it is a very bad ulcer, you need bony procedure. You can see here the bony procedure was done and the flap was done. And this 2 years ulcer healed within 2 weeks time. If it is osteomyelitis, you need to remove the metatarsal. Minor toes can be removed with sliding metatarsal. You can do thus the metatarsal osteotomy, and while walking this metatarsal hair will go up and the pressure is released. So any ulcer with this kind can be healed within 3 weeks time. So it's all our minor procedures done in OPD or either daycare procedures and it heals. You can see here when we do X-ray in diabetics, you need to do it weight bearing. See in this patient, weight bearing X-ray, the heel was so high up, so he was having the forefoot ulcer and amputation done as well previously, but we corrected his TA also. You can do full metatarsal excision sometimes. This is for supinated foot, means lateral side is more pronating, supinating. So we do split transfer of the tibialis anterior and the foot is balanced, so that the lateral part is also taking the same weight. This is ulcer for last 2 years and it healed within 3 weeks time. Midfoot ulcer are mostly work of orthopedics, where sarco deformity is there. We apply in acute phase the TCC, in subacute phase you do the superfixation, and in fused end you can excise the osteotomy. So these are some sarco. Now hindfoot ulcer, means heel ulcer are difficult to heal. But yes, if you correct and tighten the tendo Achilles, the heel ulcer will heal by itself. So tendo Achilles correction is done for heel ulcer. You can see the tendo Achilles is repaired and the ulcer is healed. You can even prove it with the pedobarogram that previously the red part is now yellow. So the weight is reduced after heel tightening. So heel defects can heal. Dorsal ulcers are very much due to friction. They are not due to the pressure on the ground. So this is just the ill-footing footwear is the cause, and you remove the footwear and normal plastic surgery will help in that. So advantages of internal offloading is they are minor to small daycare procedure, no major anesthesia is required. Ulcer heal without any plastic surgery. I have not put any single graft also on this, but the cause of the ulcer is treated. Here what we do is we do dressing, various type of very costly material we apply on that. But we have not treated the root cause of the ulcer. In biomechanics, what we do is we treat the root cause of the ulcer. So patient does not require any plastic surgery. Body wants to heal it and it will heal it. And even after that, you do not need any type of special footwear. Yeah, protective footwear for diabetic neuropathy is required, but some fancy kind of footwears are not required. As we Indians don't wear footwear in our homes. So this is a very new concept, and only 11 to 12 centers in India is doing that, and we are doing it in Surat for last 1 year. Now I have treated more than 200 patients with this type, and all are healed and no one has recurred. So external offloading, yes, I have shown external offloading cases also, it's important, but when the relapse chances are more, it's costly in long term. And you can see that where does the external offloading, so when the patient is preparing for surgery, either health wise or wealth wise, or patient is not willing for the surgery. Rest all cases you need to ask them, inform them and make them understand that biomechanics surgery is the new thing and it will all surely heal. Now after this much experience, I am so confident that confidence will be seen by the patients and they are ready for the surgery. So even medical pedicure is done in my clinic. We do that for the diabetic patients as they have poor vision, they don't can bend. So we do provide nail cutting and cleaning of their wet space and all at our clinic. And this is my clinic for Gujarat Diabetic. So what you can do at your clinic as a practitioner, that when you can see this, you can refer it to higher center, maybe a color change in skin, swelling in the foot or ankle, or numbness or burning in the pain and ankle, this type of open sores. So these, I tell them this ulcer is time bomb. Anytime it can blast and it will take either your life or your limb. So heal them at this small ulcer level, and these are healed and they don't recur. If you have done the biomechanics, they don't recur. They can happen at our transfer ulcer can happen to other parts, but these ulcer will not recur. So intraitoneal fungus infections, bleeding corns and calluses, blisters, this shows ischemia or infection. Bunions also can cause some abnormal ulcers. Cracks and dry, as they don't have sweating due to autonomic neuropathy, you can do that. These all are the red signs for the diabetic patients, and if any of your patients have this, you can refer it for the further management. These foot deformities can be corrected with the help of orthopedics. And thank you.
Any queries?
Sir, quite often we find slough in the ulcer.
Yes.
How to remove that slough?
Slough can be removed by some two methods. Like these all patients have neuropathy, so they don't have pain. So better is to do it with the surgical debridement, like you do it with knife and scissor. And no bacteria is still resistant for that knife. We have resistance for all type of antibiotics, but bacteria are not resistant to knife. So do surgical debridement. They don't even need local. So if you find slough, excise it surgically. But yes, sometimes the ulcers are so small that you don't want to damage it with excising. Then there are chemical debriders also available. Usol is, you can make freshly prepared usol. Nowadays the creams called Pepe or Debridase, they contain papain enzyme. That is called enzymatic clearance. So small ulcers, you can apply these creams and they take care of that small local level stuff.
What is that?
Debridase.
Debridase.
Debridase. It's papain urea, sir. Papain urea creams are available.
Anyone else? So, thank you, Dr. Ashutosh. A nice take-home message is they take the treatment for the cause of ulcer and the ulcer will heal, right? So now we invite Dr. Tarun Chavda and Dr. Zaman for offering a memento to the speaker.